Welcome everyone. As Tracy said, I'm Dr. Subhashini Katumuluwa, or Dr. K, whatever is easier to remember. I'm super excited to be here for today's talk. I love talking about heart health because I think it's an area that we have so much great evidence for and so much that we can help people do to reduce their risk. So super important talk, and I'm excited to get started. I typically have a tendency to talk too much because I try to add too much information in. So I specifically tried today to make this a 40 to 45-minute talk so that we have plenty of time at the end for questions for you. I always put this at the beginning of my talks. As much information as I give you here of lifestyle changes, I always encourage you to just touch base with your provider first, not to ask permission, but just to keep them in the loop, especially if you're on medications, because when we make some of these lifestyle changes, you might need some changes to those medications, okay? And just as we did for my last talk, if you could hold off of your questions until the end, I'll make sure I answer all of them, and feel free to take any photos that you want of any slides that you might find helpful here. So I saw a good number of new hands here. I thought I had maybe met most of you, but there's actually a good number of new hands here. So I'll give you a 30-second little background on me. I am a board-certified preventive and lifestyle medicine physician, and I did additional training in functional medicine as well. And I take a very root cause approach when I work with my patients, so really trying to help them understand and then address the underlying root causes for why they're experiencing the symptoms that they have, as well as the current diagnoses that they have. And I take a diet and lifestyle first approach when it comes to treatment, so focusing on those 6 pillars of lifestyle medicine. I do use medications and supplements when needed, but I really try to weigh very heavily my treatment plans on that diet and lifestyle first approach. And then in the last year, I started my own telehealth practice called Before the Script, where I see patients in California. I'm licensed in other states as well, and I see them for remote lifestyle and functional medicine care. So that's a little bit of background about me, so you know who's talking to you and why I'm interested in this subject. So I'd like to start off with just a quick outline. Let me pull this back a little. I'd like to start off with a quick outline of the presentation, just so you know kind of the roadmap for where we're headed today. We'll start off with a few definitions related to cardiovascular disease, heart health, just so we know we're talking speaking the same language. I'll go over some statistics about cardiovascular disease for the US and abroad. We'll talk about a list of root causes for cardiovascular disease. Hopefully, some of these will be things that you're very well aware of, but then I'm hoping that there's some new root causes on there that aren't spoken about as much, so it'll be some new information. I have a slide about lab testing that I recommend everyone get to better understand your true cardiovascular risk. And then where I want to spend the bulk of my presentation is these actionable steps that we can all take, implementing, starting today when you walk out, if you're not already doing some of these, that are known to lower your cardiovascular risk. And then at the end, I have a resources page for you, and then I'm happy to take questions as well. And I just want to make sure if I'm speaking at this level, this is good for everyone? Yes? Okay, perfect. All right, so let's get started with those definitions. So cardiovascular disease, this is that big umbrella term. It covers all conditions that affect the heart and blood vessels. So there's a long list of them. These are some of the top ones. So coronary heart disease, which refers to heart attacks, and angina, which is where you have chest pain because there's reduced blood flow to the heart. Strokes and quote unquote mini strokes. Peripheral artery disease, which is where you have decreased blood flow to your extremities. Oftentimes it's especially the legs. Heart failure, where you have the heart muscle itself is not working properly, and then abnormal heart rhythms, as well as diseases of heart valves as well. And then under that cardiovascular disease heading, we have heart disease, which are specifically conditions that affect the heart structure and function. So coronary heart disease, so heart attacks, angina, fall under that. Heart failure, arrhythmias, and diseases of the heart valves. And then under heart disease, we have coronary heart disease, or sometimes called coronary artery disease, which is the most common type of heart disease. And these are diseases of the blood vessels to the heart. to or from the heart, right? So this is where we have narrowing of those blood vessels in the heart because of plaque buildup, which we're going to talk a lot about today. So kind of big umbrella and then a few umbrellas underneath that. Oftentimes these terms are used interchangeably, which is not a huge deal, but they're not exactly the same. So I just wanted to kind of lay that out here. So let's talk next about what actually causes a cardiovascular event. So when I say cardiovascular event, I'm speaking specifically of a heart attack or a stroke, where you have a blockage of blood flow to that organ, either the brain or the heart. So if you think of your arteries, I use the analogy of using a garden hose. If you were to slice that garden hose in half, kind of a cross section, and you're looking at the wall of the garden hose, that's like looking at the wall of an artery. So you have multiple layers in the wall of the artery. The innermost layer, which we're going to refer to a lot today, is called the endothelium. It's just one cell thick, really delicate, but very, very important layer. Under that layer is where we start to have the buildup of plaque. So plaque, you guys probably heard of that term. It's just a collection of fat, cholesterol, calcium, white blood cells. So it's a collection of all of that that forms kind of like a little volcano, and that starts to form not in the blood vessel itself, but actually in the wall of the arteries. So right under that one cell thick endothelial layer. And over time, that plaque can build up. And then what causes the cardiovascular event is when we have a rupture of that plaque. So if you think of a volcano kind of rupturing, there's a what we call a fibrous cap, so a little lid on the top of that plaque. And over time, different things, including high blood pressure, can erode away that cap and cause that plaque to rupture. When you have that plaque rupture, all that cholesterol, fat, everything inside that plaque starts to spew out into the bloodstream itself, into your blood. And the body is a very intelligent system. It knows that that should not be happening. So it activates your immune system very quickly, and it sends platelets from your immune system right to that top of that volcano that erupted, and it starts to form a blood clot there to clog up that, or to block off that ruptured plaque. Right? And more often than not, it's that blood clot that forms after the rupture of that plaque that causes the block in blood flow. So it is certainly possible for people slowly over time, as that plaque gets larger and larger, for that flow of blood through that artery to get more and more narrow. But more often than not, it's not that actually ends up causing the heart attack or the stroke. It's when that plaque ruptures, then you have a clot form that fully blocks off blood flow, and then that's what we call a heart attack or stroke. Okay? So let's talk real briefly about cardiovascular disease statistics. I think this is always really mind-boggling to kind of wrap your head around these numbers, but in the US, heart disease is the #1 cause of death for both men and women. It has been the #1 cause of death since about 1921. So despite all of our advances, it's still, for the last 100+ years, been the leading cause. And every year, over 800,000 people have a heart attack. About 3/4 of those individuals are having their first heart attack, but about 1/4 of them, it's their second, or they've had more than one heart attack. Right? And then also, this is data from the American Heart Association based on 2023 data, which is the most recent that we have. So someone dies in the US of cardiovascular disease, the big umbrella term, every 34 seconds. So that's more than 2,500 deaths per day, more than 900,000 deaths per year. So a huge number. And then specifically for stroke, which is a subset under that cardiovascular disease, every 3 minutes, someone's dying from a stroke, about 450 people a day. And from that 2023 data, they found that about 1 in 6 of those cardiovascular deaths among adults was in people less than 65 years old. So we have this artificial kind of number, I think, in our mind that cardiovascular disease only affects people in their older years, but this disease process is starting now younger and younger, in your teenage years, or even younger sometimes, laying down those fatty streaks. Right? And then globally, cardiovascular diseases are also the #1 cause of death globally, causing almost 20 million deaths, about 1/3 of all deaths globally. So a huge problem both here and abroad. So let's get into root causes, because understanding root causes is really important when we're talking about actionable steps that we can take, because we have to understand what's causing heart disease to be able to know what to address. So I love this diagram. This is from a team called Bale and Doneen. They are a nurse practitioner and physician who've dedicated their whole careers to preventing heart attacks and strokes for individuals, and they have some great learning materials. So in this diagram, you can see the tree trunk. You have inflammation in the blood vessel system, which we know that inflammation is really what kind of lays the foundation for a lot of chronic diseases. And inflammation is a natural process, right? We want inflammation to occur in the short term whenever we have some kind of trauma or damage or insult to the body. It's our body's healing mechanism. The problem comes when that inflammatory response is triggered chronically, like long term, right? Which is what happens in cardiovascular disease. And then you can see in the branches there, those are just cross sections of the blood vessels with different levels of plaque in them. So what is a root cause? Root causes are just the underlying biological and lifestyle variables that actually create disease over time. So there's a lot of well-known root causes. So let's take a look at underneath here, and I'm going to circle in yellow for you some of the most common ones that I think a lot of you have heard of, and then I'll circle in green boxes. We'll talk about some less well-known ones. So hyperlipidemia, or high cholesterol. This is a really well-known one. If you don't have high cholesterol, your body's not going to be laying down plaque, right? Because we said one of the main components of that plaque is cholesterol. Hypertension, or high blood pressure. So having high blood pressure is a well-established risk factor and root cause for heart disease, because when you have high blood pressure, the heart has to pump harder. It also damages the lining, that endothelial lining that we spoke about, the inner part of that blood vessel, which is what initially allows for plaque to start developing when you have damage to that endothelial lining. We have genetics. So we know that there is a genetic predisposition in some people, like if they have certain genes that are passed down that increase their risk for cardiovascular disease. But I want to emphasize that the genetic component is very small. It's about 5% compared to all the other modifiable risk factors, which are about 90, 95%. Okay? And I think there's a difference. We sometimes get confused when we say, oh, I have heart disease run in my family. So family history of cardiovascular disease is not always the same as having a genetic predisposition, because you can have a family history of a certain disease, but often lifestyles also run in families as well. So it's important to kind of differentiate those. There's very few actual true genetic cardiovascular risk factors. Nicotine exposure, so this is well established, right? Smoking, vaping, people sometimes think that vaping is less damaging to the heart. We now have enough data to show that it's actually very damaging. The toxins, the nicotine itself, it increases your blood pressure, increases your heart rate, causes damage to the blood vessels themselves. So that is a well-known risk factor. Other lifestyle variables, so we know that low physical activity, high body weight, so obesity, high stress that's unmanaged, all those different lifestyle variables also increase cardiovascular risk. And then these are now some lesser known ones. So we do know already, it's very well established that having diabetes type 1, type 2 increases risk for cardiovascular disease, because having those chronically elevated blood sugar levels causes inflammation in the body, can be damaging to that endothelial lining. But I also want to point out here, this is insulin resistance, not necessarily with diabetes, right? So pre-diabetes or before pre-diabetes, because insulin resistance is a spectrum. There's nothing magical that happens at a hemoglobin A1C of 5.6 that isn't happening at the pre-diabetes cutoff of 5.7. It's a process. So even lower levels of insulin resistance increase your cardiovascular risk. Inflammatory diseases, so autoimmune diseases, having things like conditions like rheumatoid arthritis, lupus, inflammatory bowel disease. These are well established now to increase cardiovascular risk. Why? Because inflammation, you can't limit it to one organ system. When you have inflammation in your GI tract, it doesn't just stay in your GI tract. Every organ in the body is communicating. So inflammation in one organ system contributes to inflammation overall, which increases cardiovascular risk. Obstructive sleep apnea. So this is a big one. It's estimated about 30 million people in the US who have sleep apnea. About 80% of them are undiagnosed. So sleep apnea, another one that you all might be aware of, it's basically when you sleep, your airway closes, so you're preventing enough oxygen getting to your brain or in your whole body multiple times throughout the night, multiple times per hour throughout the night. And so that is known to increase your blood's risk for clotting. So just by having untreated sleep apnea, it increases your clotting risk, increases your blood pressure, and causes chronic inflammation, increased oxidative stress throughout that entire night. And when you think about it, this is every single night. If you have untreated sleep apnea, it's like lighting a little fire, right? You can do all the right things during the daytime, and then you go to sleep and you're lighting that little fire, creating inflammation. Low vitamin D, this is a big one. I find so many people aren't getting tested for low vitamin D because of insurance issues, right? Providers are unfortunately reluctant a bit to order this, but low vitamin D increases inflammation, and that's a known risk factor. Gut dysbiosis, we kind of talked about this a little bit. Inflammation doesn't stay in one system. When you have imbalances in your gut, that inflammation can contribute to inflammation throughout the whole body. Periodontal disease, so diseases of the teeth and gums, we have an oral microbiome, right? Different from our gut microbiome. When we have an imbalance up here or we have inflammation in the gums, different infections going on that aren't treated, that inflammation, again, communicates through the blood vessel system, through chemical messengers throughout the whole body. And then the last two here, psychosocial issues. So anxiety, depression, chronic stress, all of these, it doesn't stay up in your mind, right? All of this, there's communication everywhere. When we feel stress, when we feel anxiety, when we feel depression, the body converts that through chemical messengers, through hormones like cortisol. Chronically elevated cortisol, which is our main stress hormone, creates a foundation of inflammation that's just surging through the whole body. Okay? And then last but not least, lipoprotein A. So this is a genetic risk factor. You can test for this in the blood. I'll talk about that on an upcoming slide. Having an elevated level of lipoprotein A increases your blood's risk for clotting. It also makes it more likely that at a lower cholesterol level, lower LDL cholesterol level, your body will be more likely to create plaque. So I've had some patients who they have an elevated lipoprotein A, but perfectly normal cholesterol levels, even optimal cholesterol levels, those individuals are still at a higher risk for cardiovascular disease. And unfortunately, we don't have any lifestyle factors that we know of that can actually reduce that lipoprotein A number. But it's still important to know that, because then it might impact how you address some of the other root causes that you have, or how intensively you might go after some of those other root causes. Okay. So how many, just out of curiosity, how many people had some kind of new risk factor on here, or root cause that you weren't aware of before was a root cause for cardiovascular disease? A few hands at least? Okay, good. So let's talk next about lab testing to understand your risk. So I'm going to run through these relatively quickly, but I have an entire blog post that goes into these in much more detail. So when we're talking about cardiovascular disease risk, we obviously need to test cholesterol levels. That's one of the most important things. And I always recommend an advanced lipid panel. So a standard lipid panel is what most people get done. That includes the first 4 tests on here: your total cholesterol, the HDL, quote unquote good cholesterol, triglycerides, and LDL, or quote unquote bad cholesterol. But we know that looking at your LDL particle number, which is looking at how is that LDL cholesterol being packaged and transported around the body, that's important. ApoB is really important. That is basically a marker for all the types of cholesterol that can go into forming plaque. So it's not just LDL. If we're looking at only LDL, that's telling us only part of the picture. So that's why that ApoB number is so important. And then I mentioned that genetic risk factor of lipoprotein A. This is just kind of an FYI for if anyone wanted to get these tests done, what they're called at Quest and LabCorp. Anyone can order these. You can ask your primary care to order them. It doesn't have to be a functional medicine provider or a cardiologist. And then a bonus but very important test that I think everyone should get done is called an omega check. It's where they can actually test the amounts of EPA and DHA in your blood. Those are the two most studied omega-3 fats that we know to be protective for the heart. And I think this is super important because that way you're not guessing when we're making dietary changes or deciding whether we should take a supplement or not. We're doing it based on a specific number, right? Because everyone is different, how we absorb and digest our food and the nutrients that we can get from it. Looking at markers for insulin resistance, so a comprehensive metabolic panel. A lot of people get this done at their annual visit. That includes a fasting glucose and liver function tests, and then also looking at a hemoglobin A1C and fasting insulin levels. Those are really simple tests to get done and very important. Then we have markers of inflammation. So HSCRP, this is different than CRP. It's a little bit more sensitive, and it's associated when it's elevated, a increased risk for cardiovascular disease. And then homocysteine is another one. And then last few labs here, so vitamin D, because again, we spoke about why low vitamin D is a root cause for cardiovascular disease and inflammation. So that's an important one. And then I also added in a complete blood count and an iron panel, because with the complete blood count, or CBC, we're looking to rule out that someone has anemia. And with the iron panel, we want to make sure someone's not iron deficient, because with both of those, you can have them separately or together. With both of those, your heart is going to have to pump faster, because if you're anemic or not, or iron deficient, your blood is less able to carry and transport oxygen to different cells in the body. So to get adequate oxygen there, your heart muscle is going to have to beat faster. So you're going to have a higher, which in the short term, not a big deal. If our heart does this all the time, right? When we're exercising, it increases and beats faster. But the problem is when this is happening over a chronic period of time, years or even decades. And I've seen this myself with iron deficiency. I got an iron infusion, and immediately my resting heart rate dropped by 10 beats per minute. I had always told myself, oh, it's just I'm not exercising enough, I'm not, conditioned enough, but it was just 10 beats per minute immediately with that little change. So, I cringe to think how many years my heart had been working extra hard, and this was a simple fix, right? All right, so now we get into the good things for the next 20 minutes or so, the actionable steps that we can take to lower cardiovascular disease risk. So I'm going to start with some of the obvious things. If there's anyone who smokes or vapes, inarguably, right? The absolute biggest risk reduction that you can do is to quit smoking or vaping. Minimizing or eliminating alcohol. This sometimes comes up as like a questionable thing because people say, well, what about red wine, right? We now have enough data to suggest or to tell us pretty definitively that some of those possible small benefits that we saw before is likely more that the diet that alcohol was associated with, like a generalized Mediterranean diet, was all the benefit of all those plant foods was probably offsetting any negative effects of that alcohol. Because it's important to remember, alcohol in any form is a toxin to the body. It's a toxin to the cells. The liver has to detoxify and get rid of it, right? So obviously alcohol consumption is a personal choice, but just kind of keeping in mind the effects that it has. Maintaining a blood pressure in an optimal range. This is a really big one. An optimal range being less than 120 over 80 for pretty much everybody. I have a lot of patients who come to me and their top number is 130, 140, and they're like, oh, my primary care says that's okay, it's not that big a deal. But sure, in the short term, not that big a deal, but chronically over years, decades, that has a big effect on your blood vessels. So there's a lot of the things that I'm mentioning as actionable steps here are things that will naturally help to lower your blood pressure. And there's a few exercises that I'm going to tell you at the end as well. But also, even whether you're on medication or not, but especially if you're on medications, make sure to have that conversation with your primary care doctor about what do you think is causing my blood pressure to be elevated. Too often we put the label of essential hypertension, which just means hypertension for which we don't know the cause, but oftentimes it's not that we don't know the cause, we just haven't dug far enough, right? Is it that you're consuming too much sodium? Is it untreated sleep disorder like sleep apnea? Is it high chronic stress, right? So digging into that a little bit more. Maintaining a healthy weight. This is, again, a very broad recommendation, but a lot of the things that we're going to talk about in these next few slides help support that. Know your lab numbers. So the lab slide that I had before, if you don't know what your numbers are, you can't truly understand your full risk and make actionable steps, right? So knowing those numbers, and then a few recommendations for cutoffs here. So total cholesterol on the lab report itself, it says less than 200. It's not going to get flagged as being high unless it's over 200. But we know if your total cholesterol is less than 150, your LDL cholesterol is ideally less than 70, there's a much, much lower risk that you're going to actually start to build up plaque. So those are the numbers we really want to aim for. Optimizing nutrition. So this is going to be like 2 or 3 slides here. So there's a lot of little things that we can do that are very evidence-based to lower our cardiovascular disease risk. So reducing sodium. So there's the general recommendation, I think, is for less than 2,300 milligrams of sodium. That's super high. We really want to go much less than that. So even if you consumed no additional salt, even if you're adding no additional salt, you're actually getting plenty of sodium from your whole plant foods. It's not necessary to get something on top of that for most people. But if you are adding salt, minimizing to less than 1,500 milligrams a day, which is about a teaspoon and a half, right? And keeping in mind that most of our added salt, our added sodium, we're getting from ultra processed or processed foods or when we go out to eat. So the more we're cooking at home, the less sodium we're going to be getting. And then thinking about easy swaps also. Like I like to use citrus a lot, and that allows me to reduce the amount of salt that I'm using. Like in the tzatziki sauce, I have a whole juice of a whole lemon, and that allowed me to put a lot less salt in. So just a pinch of salt to kind of enhance those flavors. Prioritizing a whole food plant-centered eating pattern. So that's what we're doing right here. So that helps for so many different reasons, right? So focusing on those 6 whole food plant-based ingredient groups, tons of fiber. So how's that helpful? Fiber helps to reduce the amount of cholesterol from the diet that we're absorbing, right? Antioxidants, reduces inflammation, reduces the damage from oxidative stress in the body. And then phytosterols. So phytosterols are specific plant-based compounds that are in certain foods and help to essentially lower LDL cholesterol, similar to a medication, but naturally from your foods, okay? Not quite to the extent of a statin or so. And then diversity is really important here as well. I'm always talking about diversity, especially when we were talking about gut health, aiming for at least 30 different plant foods per week. It sounds like a really big number, but just taking note of kind of where your diversity is at now, and then seeing, okay, can I add in 1 or 2 new foods each week, okay? Minimizing saturated fat and dietary cholesterol. So I have a whole slide on this because this is often one that confuses a lot of people, especially with eggs. So I have this reference linked for you guys as well because I thought it was an interesting one to read. So it's a paper that was put out in 2010 by the Canadian Journal of Cardiology called Dietary Cholesterol in Egg Yolks, Not for Patients at Risk of Vascular Disease. So this was written by 3 physicians who are researchers, and they're heads of different research organizations in Canada that focus on cardiovascular disease. So they put out, and instead of kind of paraphrasing, I wanted to read this out specifically because I thought it was quite powerful how they wrote it. So diet is not just about fasting cholesterol. So fasting cholesterol being what we are testing when we do our blood testing, because we do those fasting. Diet is mainly about the postprandial, after meal, effects of cholesterol, saturated fat, oxidative stress, and inflammation. A misplaced focus on fasting cholesterol obscures 3 key issues, which they go on to list as 1, dietary cholesterol increases the susceptibility of LDL cholesterol to oxidation. So LDL cholesterol, when it gets oxidized, I think of it kind of as rusting, right? When you have rusted cholesterol, it's pro-inflammatory. It's more likely to go into forming plaques. So we don't want the LDL cholesterol that we have in our body to get oxidized. So dietary cholesterol increases the likelihood that that LDL will get oxidized. Dietary cholesterol also increases the after meal amount of fat that is flowing through our blood vessels. And then 3, dietary cholesterol worsens the negative effects of dietary saturated fat. So sometimes this is called the bacon and egg effect, where the saturated fat from bacon plus the dietary cholesterol from egg yolk combined have cause a much greater increase in the amount of fat that is flowing through our blood vessels after a meal, high saturated fat, high dietary cholesterol meal, and also increases the rate of LDL oxidation compared to either one of those ingredients or components individually. And that brings us then to the question of, well, why do we care that if we have for a few hours after a meal a high amount of fat flowing through the bloodstream? Well, we know that that's that's an independent risk factor for cardiovascular disease, increased damage to the blood vessel lining. And if you think about, for a lot of Americans eating a standard American diet, it's not just one meal that's like this. They have breakfast, and then maybe lunch and dinner are also like that. So you are basically staying in that high elevated state of having a lot of fat flowing through your blood vessels. Okay? So I like that this focused on, it's not just about testing your fasting blood cholesterol levels. It's important to remember even a few hours of having an elevated amount of fat and increased oxidation in the bloodstream is a problem. They also go on to say here that although some studies showed no harm from consumption of eggs in healthy people, this outcome may have been due to lack of power to detect a clinically relevant increase in a low-risk population. So what does this mean? It basically means when you take a healthy population and you're looking for a disease that is not prevalent, so there aren't many cases of that disease in that healthy population, you basically have to study a really large number of individuals to see the effect that you want to see, that you're testing for. So if you test too small of a population, it may look like there's no connection, but it's actually kind of like a false negative, right? You just didn't test a large enough population. And then the last thing they said here was the same studies showed that among participants who became diabetic during the study period, it actually found that consumption of one egg a day doubled their risk of a cardiovascular event compared to people who ate less than one egg per week. Right? So, and when you consider that more than 50% of Americans either are diabetic or pre-diabetic, this is something that is super important to talk about, right? So a lot of the confusion around eggs, I think, even among the medical community, is not because we don't have the data, it's because of how we're presenting it, right? We're not showing the full picture there, because when you do look at all the data, it becomes very clear. And then staying on the topic of fats there, when we are eating fats, choosing whole food fats like nuts, seeds, avocados, olives over refined fats like oils. And if you do cook with oils, I do sometimes, but I make sure that I'm starting to measure it, right? Because we always underestimate when we're using what we think is a tablespoon is actually a lot more. So even if you're choosing to use oils, just measuring it out makes a big difference as well. Adding in omega-3 fats. So omega-3 fats we touched on before. These are one of the most anti-inflammatory, protective for the heart fats that we can consume. If you're looking at food-based sources, seaweed is a great one to get EPA and DHA directly. You don't want to overdo it. It's a good source of iodine, but too much of it, you can have too much iodine. And then chia, hemp, flax seeds, and walnuts. These also provide omega-3 fats, but a different type called ALA, alpha-linolenic acid. ALA can be converted in the body to EPA and DHA, but it happens at very different levels of efficiency in each of us. And this is where I think it's really important to get the testing done, because otherwise you could be eating all the right things, but maybe your body's not converting it appropriately. And so you're not really getting what you think you're getting. And then when you have testing done, and I've had this done myself, and I have yet to meet actually someone who's eating a plant-based diet, even very diverse, who's naturally getting enough omega-3 fats, specifically that EPA and DHA, to hit those levels that we know to be protective for the heart. So sometimes taking an algae-based omega-3 supplement, EPA or DHA is necessary, and again, the dosing you can figure out based on what your level is, but it's super important if you are going to take a supplement to make sure that they're doing third-party testing for heavy metals, because that's a big one, whether it's fish oil or algae-based products have the same issue. Adding in more legumes. So this was a really interesting study where they did a randomized controlled trial, and they found that 2 servings per day a total of 1 cup cooked of legumes, any combination of what I listed there, lowered total cholesterol by over 17 points and LDL cholesterol by nearly 15 points. That's a huge amount. And when you take into consideration that each of these things that I'm telling you can lower cholesterol by a little bit, when you add those up, they have an additive effect. So you don't need one change to have the whole impact, right? And there's obviously lots of really interesting ways, delicious ways to add in beans and legumes into your diet. You can add some beans, legumes into grating bowls like we did here, add them into soups, stews, salads. This was a fun one that we came across, and we've made this a few times at home. These smashed Caesar tacos, where you're basically just putting a bean mix, a mashed bean mix, onto small tortillas, toasting it in the oven so it gets nice and crispy. Then we topped it with some lettuce, some smoky tempeh that I made, vegan Caesar dressing. And for 2 of these tacos, which are relatively small, 40 grams of protein, almost 20 grams of fiber. That's almost double what the fiber that the average American is getting, right? So just fun little ways. That's just a QR code to the recipe here. All right, then creating a balanced plate to support more healthy blood sugar regulation. So basically just making sure that you're taking a quick snapshot of your plate, making sure that you're having a good balance of your macronutrients. There's lots of great diagrams. PCRM has one, ACLM, all saying basically the same thing. Half of your plate, veggies and fruits, a quarter of your plate, grains, including whole grains and starches, and then a quarter of your plate, plant-based protein sources, and then small amounts of fat and dairy substitutes. So just making sure that you have a little of everything when you're consuming a meal. And then the last one here for nutrition, black cumin powder. So this was a really interesting study. So black cumin seeds, they look kind of like black sesame seeds. It's just a spice. You can grind it in a pepper grinder. And in this study, they had, it was specifically in postmenopausal women, where they had them take just a quarter teaspoon with their meal, with one meal every day. And over the course of 2 months of doing this, they found there was a 27% reduction in their LDL cholesterol, which is huge. That's a huge, huge drop. And there are other studies that have shown that black cumin powder can be helpful for more general populations. I wanted to highlight this one on postmenopausal women because the risk for heart disease increases after menopause. Why? Because estrogen levels drop. Estrogen is protective for the heart. So oftentimes after menopause, we see blood pressure increase, cholesterol levels increase, and abdominal weight gain. That visceral fat, which makes us more insulin resistant, more inflammation, increases cardiovascular risk. So especially in this population, a really simple thing that we can add in. Okay. All right, so those were all the nutrition ones. We're getting towards the end here. Movement. So we know basically every kind of movement has been studied and shown to be helpful in reducing cardiovascular risk. And we want to include all of them. So I would say at a minimum here, like these are all kind of at least requirements, right? For cardiovascular disease, for cardio exercise, at least 150 minutes. That's as little as 20 minutes a day, but ideally we want to be doing more than 20 minutes a day. Has been shown to help with our cardiovascular disease risk. Resistance or strength training at least twice a week, but ideally 3 to 4 times a week. And keep in mind that building muscle is so important, especially as we get older. It's important across the lifespan, but especially as we get older, for helping with so many things, but also blood sugar regulation, because your muscles are basically a glucose sink, right? Your muscles use up glucose, and it helps you to maintain healthy glucose levels even when you're not exercising, if you have more muscle. Isometric exercise is a really, really big one that I especially wanted to touch on for cardiovascular, for blood pressure lowering. There's a really interesting study. So first of all, I'm getting a little ahead of myself. Isometric exercises, what are they? They're basically where you hold a muscle contraction. So there's no movement, you're holding a position still while contracting the muscle. So wall squats, where you're basically sitting at like a 90-degree, whoops, not that wall, like a 90-degree angle, right? Like you're sitting on a chair. And hand grip, you need like a hand grip strength little device. And then leg extensions, where you're sitting in a chair and then sticking both legs out and contracting that quad muscle really tight. So they did a super interesting study where they looked at 270 studies that were done looking at different types of exercise. It was a meta-analysis using statistics to kind of look at all of that information. And they studied how different types of exercises impact blood sugar lowering, or I'm sorry, blood pressure lowering. They looked at aerobic exercise alone, aerobic or cardio, strength training alone, a combination of aerobic and strength training, isometric exercises, and then HIIT or high intensity interval training. They found all of them did help lower blood pressure, but of those, the one that lowered blood pressure the most was isometric exercises, which is really great because for people who have low mobility or maybe joint pain, they can still do these exercises and get that benefit. And of the isometric exercises, wall squats were the most effective at lowering blood pressure. They lowered blood pressure by the top number, systolic blood pressure by more than 10 points, that bottom number by more than 5 points. That's a big drop in blood pressure. And how did they do that? So all these studies, they did the isometric exercise 4 times, held that isometric exercise, that position for 2 minutes each time, and had a 1 to 4 minute gap in between. The wall squat is very difficult to do for 2 minutes. I timed myself. After about 1 minute, my legs were were shaking a lot. So you can work your way up to that, but also the leg extension is much more doable, and you can still really start to feel that aching in your quads when you do it the right way. So if you think about that, that's 8 minutes 3 times a week, and within 6 to 8 weeks, they were seeing these effects. So really easy thing for us all to be able to add in. And then I have stretching here, not because there's any specific evidence showing that it helps reduce cardiovascular risk, but stretching is how we maintain our mobility as we get older for all of us. And so the more mobile we are, the more we can do all those other things on that list, right? So adding in some stretching daily. Optimizing and prioritizing our sleep. So this is a big one. Duration and quality of sleep. It regulates our blood pressure, our heart rate, and how our bodies are able to process glucose, right? You'll notice after a poor night of sleep or where you get only a few hours of sleep, the next day your blood sugar levels tend to be higher even if you're eating the same exact thing. And then also ruling out sleep disorders. As I mentioned, this is if you snore at all. Snoring, we've kind of normalized it in our society, but snoring is not a normal phenomenon. If it just happens when you have a cold, okay, not a big deal. But if you're noticing that your partner tells you that you snore or someone has told you that you snore, that's something definitely to get checked out to see whether it's just a structural issue or is it actually something like sleep apnea. And then last but not least, building stress resilience. So I have this term here, curate your stress. So there's a lot of stressors out there. We can't control all the stressors, but we can, certain things even that are stressors that are out of our control, we can control how we bring them into our life, right? So an example being all the horrible things happening in the world, not just in our country, but all around. A lot of us want to know that information, be up to date with it, but we can time how we take it, right? First thing in the morning when you're laying in bed, picking up your phone, reading the news, which I sometimes do, and then, I'm not in a good mood right off the bat, or right last thing that you look at right before going to bed. Probably not the best times to take in that information, right? So can control your stress as much as you can. That's a big part of it. Exercise is an excellent way for stress release. But I also recommend that if you're not already doing it, finding an active way to practice present moment awareness or mindfulness, right? This could be a formal practice like meditation. It could simply be taking 2 minutes to practice deep breathing at the beginning or end of your day. It could be turning on some really calming music, closing your eyes and just listening to the music. Going out for a walk without your headphones, without talking on the phone or talking to someone, and just noticing what's around you. Lots of different ways that you can practice mindfulness in just everyday activities, even without a formal practice. It's just different than relaxing, right? Relaxing is you just turn on the TV, shut off your brain. That's very different. We're not actually cultivating mindfulness there. Okay? So that's kind of all of everything that I wanted to get through, and I think I stayed pretty close to my time limits. I have some references here. I have this, these are some of the most interesting presentations that or talks, sorry, studies, research papers that I presented to you, but I have this info for you here. I created a page on my website so that I have the references with links to them there. I have that blog post I mentioned with the top 10 labs that you should consider. And then I have two handouts on, basically, these are the same two that I had at the gut health talk, basically helping to encourage us to consume a more variety of plant-based foods. And then if anyone's interested in guided meditations, I love the Insight Timer app. It's a free app. They have over 300,000 different guided meditations on there. I just started doing some recordings and posting, uploading them to Insight Timer. And they also have live meditation options from thousands of teachers around the world. And I'll be leading a live meditation, not this Monday, but the Monday after that, a loving kindness meditation. So I have to sign up for that as well. And that is everything that I wanted to go over. So I'm happy to take any questions that you guys might have now. Yes, go ahead. Thank you.
Fiber in a blender, does that make it less valuable for your body?
No, it makes it, I mean, I think there's a certain benefit to chewing, right? Because you're sending other signals to the body. That process of chewing is releasing digestive enzymes and stomach acid. But breaking down the fiber, you're still getting all that fiber. So if that's an easy way for you to get in some extra nutrients or get in a meal, that's perfectly fine. Yeah. And it's very different than when you're juicing, right? You're keeping all the fiber in there. So I think that's a great way to add it in. Yes.
Yes, I noticed on your slide that had the plate, there was a coconut, and we followed Dr. Esselstyn, and that's a big no-no. I assume you didn't make that slide, you pulled it from somewhere else, but how do you feel about coconut?
Yeah, so coconut obviously is high in saturated fats, right? So that's the reason Dr. Esselstyn takes it out. So for people, if you're having, again, it depends on what you're comparing it to and how much, right? Adding a tiny bit of, grated coconut into a granola, probably not a big deal. If someone is, for most of my patients, where I start is, what can we add into your diet that you're not consuming, right? For most of the people that I see, having a little bit of coconut is not their main problem. There's other things that they're not doing. So if it's something, I try to be, for a lot of people, if they need to be really strict, if they have a lot of cardiovascular diseases, then making those specific changes can be very helpful. But in general, I don't focus so much on, cutting all of that out. If someone needs a little bit of some coconut for something, I don't typically recommend cooking with coconut oil, but if they're adding a little coconut milk to something, and that's how they're eating more plant-based things, then I'm okay with that. But good point. Yes.
You said something about LPA is not affected by your lifestyle.
Yeah. So her question was that I mentioned lipoprotein A, or LP little a, that genetic risk factor that when it's elevated increases your risk for heart disease and for laying down plaque. I had said that it's not affected by our lifestyle changes. So that's true. We don't know of any lifestyle changes. You could be doing all the right things. We don't know of any ways to bring that number down into a safe, healthy range. There's one medication that I'm aware of, an injectable medication that has been shown to bring down lipoprotein A by about 20% or so. It's not one that I prescribe or have used, but unfortunately we don't know any lifestyle-driven ways to bring that number down. But the reason I still recommend getting it tested is because it's still part of your risk calculation, right? So knowing that you have a higher risk from that endpoint, from that lipoprotein A variable, may change how you decide to address some of your other risk factors. So maybe for someone who has high lipoprotein A, they might be a little more strict with things like the coconut oil, or really cutting out any kinds of saturated fat and things like that.
Another question. What about enzymes, where I've seen supplementary where enzymes, you take 3 of those and it breaks fat, or is that something that you would recommend? Will that help with the heart?
Sure. So she's asking about, I think, different types of digestive enzymes, so they can break down fat. There's other digestive enzyme supplements that help break down carbohydrates and protein. So I don't typically use digestive enzymes for people. I'll work on some lifestyle things as far as like eating hygiene habits. There's a lot that if you feel like taking digestive enzymes is helpful, oftentimes I find that there's something else that we're doing that's not sending the right signal to the body to say, hey, it's time to eat. We need to release our own digestive enzymes. So usually I find if you sit down taking 5 to 10 deep breaths before a meal, which is signaling to the brain, hey, we're switching from our fight or flight mode to our rest and digest mode. That certainly helps. And then sometimes even taking digestive bitters is something that I do use. Digestive bitters, it's like a bitter root extract. That bitter flavor stimulates your own body to produce and secrete more digestive enzymes. But in general, I don't typically have people take lipase or any kind of digestive enzymes, and I don't know of any research that shows that it helps with cardiovascular risk reduction. Question. Yeah. I honestly, I don't have a number like that I focus on. Oh, sorry. The question was, what is the max saturated fat amount that I recommend per day? And I forget if the even like the American Heart Association recommendation, whether it's 10 milligrams or something, I can't quite remember, somewhere around that amount. But I don't typically have something specific that I focus on. I just focus on minimizing kind of the fats that we're using. And if you're eating whole food fats, I typically find it's hard to get to that level. It's when we're adding things like coconut oil or other oils, it's really easy to kind of get that number up without realizing it. Esselstyn, okay, the Esselstyn team says no more than 6 grams of saturated fat.
If you're already following plant-based diet,
Mm-hmm.
what are other ways to
Okay, yeah. So already doing a plant-based, so the question was if you're already doing a plant-based diet, what are other ways to reduce insulin resistance? So with the plant-based diet, also making sure that it's more leaning towards a whole food plant-based, right? Little things for insulin resistance. So other dietary things are part of what I showed you with that my plate, like the picture, right? Making sure that we're balancing our meals, right? So if you're eating carbohydrates, it's not that carbohydrates are bad. It's we want to balance them with some healthy fats, some protein, because all of those things prevent that rapid rise in blood sugar. If you're consuming added sugar and things like that, making sure that you're not eating those on an empty stomach. So a pastry or sweet treat on an empty stomach for breakfast versus as a dessert after you have fat, protein, fiber in your gut has a very different effect on blood sugar. The other really big thing that you can do is different types of physical activity, exercise, right? That has a huge impact, making sure that you're building muscle. I see a lot of people doing a lot of cardio. Cardio is super important, definitely for the heart, but we can't forget about that strength training because, as I mentioned, that muscle is a glucose sink. Your muscle uses up glucose even when you're just sitting doing nothing. And as we get older, especially for women, when you hit your 40s, 50s, and that estrogen level goes down, if we're not doing actively working on strength training, we're losing muscle. All of us, actually, after 30, we're starting to lose muscle. So that becomes really important. And then sleep also. Sleep has a huge impact on insulin resistance, and I think that's a big one that we tend to underestimate as well. Sleep and stress management, both of those.
Mm-hmm. All right. I know you were promoting like doing a lab test, and I'm a doctor, and so a lot of times lab tests, what they do is that they take whatever the blood, whatever they're working on, it'll sit for a while in the lab. They put it under blue light, so by the time they actually get the results, it's not really a current method for what you know. What I'm saying is that they're not always accurate. That's where you said that you have 10 core labs that you recommend to follow up on.
Yeah, I have 10. So the question was sometimes when labs are drawn, they'll sit there, so they're not testing them immediately. There's a lot of, like, for the cholesterol labs, I know some of those, like Quest, they get sent cross country. There's like one lab in California that even when I worked on the East Coast, my lab samples would get sent out here. But we know that at least for our interpretation, like studies that have been done, they're all using this similar type of lab testing. So there is some standardization when we're looking at those lab reference ranges. Um, so while there's no testing that's like perfect, right? I think the way that we currently do them, especially like the cholesterol testing, it's still been standardized enough that when we get that result, we can at least know that with some of those cutoffs that I was mentioning, that that's a good way to interpret them. For the top 10 lab tests, yes, I have on my website. If you just go to before the script or that QR code that I have up here, it has the top 10 labs. A lot of them are on the list that I gave you here, but there's a few additional ones as well.
Mm-hmm.
Yeah.
Do you work with anything on, like, you mentioned a lot of the physical aspects. You infiltrate the physical, the psychological traits, the biological. A lot of core issues actually that issues we get into the core, what really created it. Do you work with anything on that, like
Sure. So her question was, I mentioned like there's on that root causes, some of those psychosocial root causes that are then causing a biological or physiologic change. So do I work on some of those things? So I would say the biggest part that I kind of work on is I incorporate that mindfulness training into. I talk with every single patient, whether they come to me for something related to that or not. We talk about that mindfulness training and things, and there's lots of different ways that people may address them. But for me personally, I kind of focus on that. That's the main way that I do it.
I also work with what's called heart release, is actually going in there and releasing the trauma in the heart.
Oh, fantastic.
That's like all the trauma you've had in your life, divorce, death, relationship, whatever, loss of job, all sorts of heart.
Yeah.
That's like higher than the other side. It's incredible technique that anyone know about.
Oh, wonderful.
Thank you for your presentation.
Yeah, absolutely.
Another thing too, you mentioned salt.
Mm-hmm.
This is just my idea as a belief system on this, is that we all need salt. It's like our body's like a battery. Doctors say, oh, you have this or that, lower your salt intake, lower your sodium. We need that. That's part of what body needs. And most of the salt people do need is not help your salt or
Yeah, so she was just mentioning that I had said with salt intake, she was mentioning that people need salt, so there's a certain amount that everyone needs. So yeah, the thing is, we're not, as far as sodium, a lot of us, there are natural foods that we're getting sodium from. So I add some salt to mine. It's not for me or for me, I don't do a no salt diet. It's just I'm kind of monitoring how much I'm putting in. And I find that for most people, our issue is that we end up just adding in way more than we need. Yeah. Mm-hmm. Oh, sorry.
Couple more
Did you?
questions. What about cortisol? Is that cortisol? You could explain that further.
Sure.
Like a steroid, hormone steroid that may affect the heart?
Yeah, so just the question is cortisol and what effect it has on the body. What is it? On the heart. So cortisol is our body's main stress hormone, right? It's secreted by the adrenal glands. We produce it ourselves in relation to a lot of different things, but mainly chronic elevated stress. Cortisol in and of itself is not a bad thing. We need some cortisol. It's designed as a protective mechanism to help our bodies to deal with stress in the short term. Again, like a lot of things, the problem is when a short-term process gets extended to a chronic process. So if we have repeated things that are causing our cortisol to be elevated, we're having repeated stressful events, or we're replaying those events in our mind, so that event is never ending. So that elevated cortisol does create inflammation throughout the body. And so that's where it kind of came into the root causes when we were talking about psychosocial issues or Even untreated sleep apnea. Untreated sleep apnea increases cortisol. And if you're doing that every single night over a long period of time, that is going to have a pro-inflammatory effect in the body and affect the heart in that sense.
So, if someone has genetic predisposition to heart diseases, and some of the research also suggested that the use of drugs are helpful in terms of statin inhibitor and that, how does one decide if that's the right choice to start?
Yeah, that's a great question. So the question was, I didn't touch on any statin use or medication use, and sometimes that might be needed, especially for people with a genetic predisposition. So I always, when I work, I do prescribe statins sometimes with patients. It's typically after I work on all these other variables, because I find that right now it's not that statins should never be used, it's that I feel like they're being overused because we turn to them quickly before we address these other issues. So I find that for most people, again, I spoke about the difference between a true genetic risk factor versus just it runs in the family. Like for South Asians, we genetically do have a higher predisposition to more abdominal fat, more insulin resistance, more cardiovascular disease risk in that sense, but a lot of it is also lifestyle driven. So it ends up being a personal discussion with your provider about looking at your unique risk factors and what have you been able to achieve through lifestyle changes. Are there additional changes that we can add in to lower your risk before trying a statin? And then when I do work with patients and prescribe statin, there's also nuances to that as far as dosing, which type of statin. So there's some statins that have a longer half-life in the body. So I like one that lasts about 19 hours in the body, which allows me to dose it at a much lower amount and still have the effect that I want. So there's some statins that I prescribe 3 times a week or every other day, so much at a lower dose. So it's staying in their body. It's giving me just enough help to get their LDL or whatever other risk factor I'm trying to get a little bit lower, but without needing to expose them to the full set of side effects or as much risk of side effects. Does that kind of answer your question? Yeah.
So following on from that, there was an article on the BBC News a couple of days ago about the effect of statins and all the downsides. And they were basically saying that no, there are no downsides. Downsides are extremely rare and have been wrongly reported. Is that true?
No, I mean, there's definitely, I didn't read that specific article, so I'm not sure exactly which studies they might be looking at. But the question again was, there was an article in BBC that recently said that there are basically no downsides, no risk factors to statin use. They've just been inappropriately or incorrectly reported. And so we know that there are certainly some risk factors to statin use. There is sometimes an associated increased risk for developing insulin resistance for some individuals. There is some risk of like muscle cramping, muscle damage. There's things that we can do to reduce those risks, and part of that is reducing the amount of the dose that we're using, how often we're giving it to someone. But I would personally disagree. I think there are definitely well-established risk factors, but it's not just about those risk factors. That doesn't mean that should never be prescribed. It's just that we have to weigh the risks and the benefits for that unique individual when choosing. Yeah.
You were talking about studies. Does anyone ever inquire who does the studies, who's behind the studies? That's really important element to look at.
Yeah, you bring up a really good question. When we're determining the quality of a study, always looking at who funded the study. And that's where, like with the egg studies, a big confusion there is there's a lot of studies that are funded by the egg industry. So that definitely skews it. Even some of like the dietary guidelines, for example, we think the average person would think this is an unbiased set of recommendations, but a lot of people on the council that write some of those recommendations are from different food industries. So there's definitely a link there. Yeah, so when you're assessing the quality of a research study, looking at who did the research study, how many patients are involved in the study. There's a lot of different variables that determine whether a study is good or not, but that's a big one. Yes.
So, what would be the recommendation? Let's say you have a high cholesterol and LPA and all that, but would you recommend that someone take statin right away, or if this person, decides to take the diet, like the lifestyle change, how many months before, okay, I'm going to try for 6 months, a year, and see what happens before I take statin, or should I take statin now and then, in congruence with the lifestyle change, or if this person wants to have it more, okay, let me change my lifestyle diet first. How many months we say, okay, this is before they check and say 6 months, a year, or
yeah, great question. So the question was, if you are, let's say, told that you have high cholesterol and you want to prioritize a lifestyle changes, how long is it okay to do those lifestyle changes before you reassess and then decide, okay, maybe I should go on a statin. So there's a lot of different variables there. I would say disease severity of disease is a big defining factor. So I didn't today get to talk about imaging studies that show cardiovascular risk. So if you have, for example, a high coronary artery calcium score, which shows that you have high cardiovascular risk, that would be something that you incorporate into your risk assessment with your provider to say, okay, well, maybe this person, we should start them on a low dose of a statin while we're working on some of the other changes. In general, for someone who has average, like moderate risk, I typically will have someone do 3 to 6 months of a dietary change. Again, that's just a very broad recommendation. It's a very personalized thing depending on someone's individual risk. But I would say 3 months is if you're really making all the lifestyle changes. That's the other thing. It depends on how quickly someone's making the changes, right? You can make one, if someone's willing to make one little change, but they're still eating a lot of unhealthy foods, you're not going to see the effects as well. But if someone's going to do a 180, switch to a whole food plant-based diet, do it really strictly, do all the exercise and all that for 3 months, there's a ton of change that we can see in people. And a lot of these studies are done in that shorter time period, like 2 months. A lot of these studies, these interventional studies, where we then see an impact. So it depends on a few different variables, but I would say severity of disease is one big thing to consider, because if you have imaging studies that show you have disease, then that kind of trumps all the other lab tests, because we're typically using lab tests as a predictor of possible disease. But if I see disease in you, I don't need to, the fact that your LDL cholesterol is like a little bit elevated, it's a different discussion then, because we actually see the disease in you. Does that make sense? Yeah. Oh, 2 more? Okay.
If you have a high calcium score,
Mm-hmm.
is there anything else you can do? Calcium, I don't think you can get to go away. You can the plaque, not calcium.
Yeah, so the question was, if you have a high calcium score, so this is on a coronary artery calcium score test, which is like a CT scan where they're looking for calcified plaque, is there anything that you can do that can get that calcium score down? So one point I also want to make, when it comes to a calcium score, that calcified plaque is not actually the dangerous plaque. That calcified plaque, that's your body's essentially way of kind of healing that plaque and stabilizing it. So that calcified plaque is not what is at risk of rupturing, but we associate that calcium score with your cardiovascular risk, because we know if you have a high calcium score, you have a lot of calcified plaque, you definitely have soft plaque also, because soft plaque has to develop first before you develop calcified plaque. So if you have a high calcium score, we are essentially using that to assume that you have a lot of soft plaque. So in that case, we don't necessarily target just that calcium score. There's not a great way. We do have actually some studies when you have when you do take statin therapy, sometimes we can see a stabilization in that number. But I would use that more to focus on what are the lifestyle things that we can do that we know to reduce that development of new soft plaque, which is at risk of rupturing. Does that answer the question? Okay, last one.
I've noticed that when my blood sugar is higher, LDL is higher. I want to know why that is.
Gonna squeeze in a sip of water. Okay, question. I know.
Did you get one?
No, that's okay. Question was, she's noticed as a type 1 diabetic that when her blood sugar is elevated, it increases her LDL also. And why is that? So there's kind of multiple mechanisms, I'd say. Oftentimes when we have high blood sugar, it contributes to your body actually producing more cholesterol, because a lot of the cholesterol, right? So about 30 to 60% of the cholesterol in our that we eat actually gets absorbed, but our body produces a lot of cholesterol in our liver too, and that has a lot to do with our insulin resistance and blood sugar levels. So I would say probably that's the biggest component there, is because of that link between blood sugar levels and how much cholesterol our own body is producing. Okay. All right, thank you everyone.
All right.